Okay, we're going to be covering some musculoskeletal disorders. We're going to start with fractures and some of the classifications of fractures and features and how they're named and whatnot. Um, so a fracture is a break in the integrity of the bone, and fractures can happen not just from trauma, right? I mean, that's obvious. Some people think they slip, they fall, and they break their humerus or their wrist or the radius or clavicle, or break their hip. But neoplasms can also create fractures and stress on bones. Now, um, I have known many young students that are athletes that have gotten stress fractures, um, primarily of the feet, especially the metatarsals, and they say they didn't do anything. So it leads us to believe that they're not very healthy, because just from walking alone, you should not break a metatarsal. Um, it doesn't matter if a person is athletic. There's a huge difference between being physically fit or being an athlete and having good physical fitness compared to being internally healthy. In fact, you could speak to many um, healthcare providers that work with athletes like myself, and over 25 years of experience, I can tell you with certainty that most athletes are the most unhealthy people. They may be physically fit, they may be strong, they may be oxes, they may have, great physique, but in terms of health, internal health, um, far from it. Unless they have really good coaches and good nutritionists, and they get good neuromusculoskeletal treatment and care, but most are not. So when people are in a state of chronic inflammation and they don't know it, that's how a lot of fractures take place. Fractures are charted using the number sign. Okay, a lot of people didn't know that. So some of the classifications of fractures: there's a complete fracture, which is a bone that's broken and it forms separate pieces. Complete. An incomplete is when the bone is only partially broken. And we'll get to some pictures that demonstrate this and show it. There is an open fracture and a closed fracture. Open, that's sometimes referred to as compound. These are fractures that result in the skin being open. So the bone breaks through the skin, and can result in a lot of soft tissue damage, blood vessels that get ruptured, and as well as nerve damage. And when that happens, especially with an open fracture, there is the risk of infection, because the first line of defense, which is the skin, is now open. A closed fracture is when you have a fracture, but the skin has not, or the integrity of the skin is not broken. So here is a example of a simple fracture. Well, let me go up here. Looks like we skipped something. So a simple fracture, a segmental fracture, a comminuted fracture, a compression fracture. Some of these are named depending on the number of actual fracture lines. So a simple fracture is when there's a single break, right? We could see that here. That is a simple fracture. A segmental fracture is when there are several large fragments that separate from the main body of the fragmented bone. So we could see that this looks like it is the ulna, and it is. Here's the head of the radius. Here's the distal humerus, the olecranon process, the coronoid process, and we could see that it's fractured here and here, and you got one, two, you got three different segments. That's a segmental fracture. A comminuted fracture is when there's multiple fractures in bone fragments. And we'll show you a picture of that as well. It's like it's not segmental where we see three different segments. It's really, when it's comminuted, it's broken in just one place, but there's several fragments of bone that shattered in that one place. Okay, let's go back here. A compression fracture, this is when the bone is crushed and it collapses. We see this commonly with osteoporosis, and the vertebra create this type of codfish type of deformity or wedge shape. And we'll show you what the compression fracture looks like in a second. So here's comminuted, right? Here's the scapula, here's the glenoid cavity, here are the ribs. We can see the inferior angle of the scapula here. Here's the greater tubercle of the humerus, lesser tubercle of the humerus. We can see that it's fractured here and it's comminuted. We have 1, 2, 3, 4, 5 different fragments through this one region here. Here's a compression fracture. This is showing the thoracic spine, and we're looking at it from the lateral view. Okay, this is anterior, this is posterior, and these are the ribs that are coming off of the thoracic vertebrae. Right here, you can see that the posterior portion is vertically higher, right? Like here, look at the height here, and look at the height here. That's healthy. You can see the end plates are intact. But here, look, goes like this on the superior end plate, and let's look at the inferior end plate. It's compressed. It creates a wedge. So this can heal. Hopefully it's stable. With some bed rest, they'll get better. Usually with spinal fractures, there's a lot of vomiting and nausea, typically seen with, especially with spinal fractures. So it's part of my case history when I evaluate someone that had a slip or a fall and they land on their butt pretty hard and they can't move and they go, I've been throwing up all night. You know, we say, you know, call the fire department, call an ambulance, and let them bring you over and get some x-rays and stabilize you. I think you have a spinal fracture. Other types of fractures. Impacted fracture, that's where one end is forced into the adjacent bone. There's a pathological fracture. These are called spontaneous fractures. This results from bone weakness as a result of a disease. Okay, this can occur with very, very little stress. So there has to be some sort of underlying inflammatory condition that results in a spontaneous fracture. Okay. Stress fractures, these occur from repeated excessive stress. Typically, these are found in the lower limb, especially in the feet, typically the metatarsals. Depressed fracture, these are very specific for skull fractures, where there is a fragmented part of the skull and it's forced and depresses into the brain. Okay, that's pretty serious stuff. Here is impacted fracture, where here's the hip, here's the acetabulum, obturator foramen, right here is the ischium, head of the femur, greater trochanter, and here's the shaft. Now the neck should be a lot longer, and the neck has compressed or impacted into the head of the femur. Okay, this looks like, this is the knee joint. This looks like it's the distal end of the tibia. And here, it kind of looks like, if you look at the periosteum here, you can see that it's fractured. And then it looks pretty much radiolucent, right? Bone should look white because it's calcium. Calcium always shows up as bright white. When the inside of the bone starts to look like the same density as the outside, then we have some problems, okay? So this is definitely a pathological fracture. Looks like Swiss cheese in here. Here's a stress fracture. We can see here on the middle shaft of the second metatarsal. This is the foot. This is the hallux, the great toe. First metatarsal, second, third, fourth, fifth. Here's the navicular, talus, calcaneus, first, second, third cuneiform, and the cuboid right here. Here's the depressed fracture. Here's the skull. You can see the orbit of the eye. You can see the mandible right here. You can see the cervical spine. And then right here is that depressed fracture going into the brain. Pretty serious stuff here. Other type of fractures, there's a transverse fracture, linear fracture, oblique, And spinal fracture, it's really named after the direction of it. So if the break runs straight across the bone, it's a transverse fracture. If it runs along the long axis of the bone, it's a linear fracture. If it runs on an oblique angle, we call it an oblique fracture. And if a break occurs by angling around it, like a spiral, then we call it a spiral fracture. Then there's other unique names, a Colles fracture and Pott's fracture. Colles happens when someone falls with an outstretched hand. They break the distal end of the radius and it kind of dislocates. When it dislocates posteriorly, it creates a type of deformity called a dinner fork deformity. And we'll show you what that looks like. It looks like a fork, the same shape. A Pott's fracture is a break in the ankle region. It's the lower fibula where that lateral malleolus is due to excessive stress. Maybe the ankle rolls in or rolls out, or you slip off a curve or down the stairs. That creates a Pott fracture. So here is the arm. Here is the left arm. They're not in anatomical position, but the radius would be here. Here is the ulna. Here's the pinky side. And here's the dinner fork. So right here is the distal end of the radius, and it dislocated posteriorly, creating this deformity. Here is your Pott fracture, and here's the medial malleolus of the tibia. Here's the shaft of the fibula. Here's the lateral malleolus, and you can see that the ankle rolled in, and it looks like it tore some of the ligaments on this side, and due to that type of stress, the lower end of the fibula fractured. That's a Pott fracture. We could see it here on the x-ray as well. Here's the tibia, here's the fibula, here's the articulation between the talus, and that's your hinge joint for dorsiflexion and plantar flexion, and that's where it broke. So you could take a few seconds, you can pause here and take a look at some of these fractures. We spoke about the oblique, comminuted, open, goes through the skin, segmented, you have 1, 2, 3 different segments. Here's the spiral wrapping around the bone, transverse, straight across, impacted. You can see the head of the neck is impacted into the head of the femur. The Colles fracture is the distal end of the radius is fractured. Here's the ankle fracture, the Pott fracture. Here's your compression of the vertebra. And the one that we didn't cover is the green stick. Happens in young children. Where it kind of splinters. You know, the bones are still very flexible. If you take a green stick in nature and take both ends of the stick, your right hand grabs one end of the stick, your left hand grabs the other end of this green stick, and you bend them, you could bring both ends together, and you'll get a little splintering. It won't break completely in half, but on the convex side or the top side, when you bend it, it just kind of splinters a little bit, but it still stays intact. This is the splintering of it, okay? All right, let's look at some of the pathophysiology of fractures and then the stages of healing, what some of the complications may be, signs and symptoms, and treatment. So the pathophysiology of fractures initiate an inflammatory response, right, because it still has to heal, and hemostasis. Hemostasis means there has to be this pooling of blood that takes place in that area. So the bleeding is going to come from the blood vessels in the bone, right? We know that in compact bone, there's the Haversian canal or Volkmann's canal, and it's got the arteries and veins and lymph vessels and also nerves that travel through there. Their bones are vascular because how else are nutrients and minerals and calcium stored in bone? The periosteum, the outer part of the bone, is also vascular, and when it breaks, you're going to bleed, and you're going to get this pooling of blood that's going to stagnate in that area, and it's going to form like a tumor of blood, which is called a hematoma. Okay, this is normal. It's going to form at the fracture site, and the purpose of this hematoma is going to serve as the basis for this granulation tissue to grow. Okay, it's going to kind of create this fibrous type of cartilaginous callus type of connection, and then it's going to harden up, and that soft callus is going to be converted into more of a hard callus, and then eventually it will start to remodel itself between the osteoblast and osteoclast activity. An inflammatory process develops from the trauma and the presence of the debris at the fracture site. There's going to be edema, which can cause stretching of the periosteum if it's still intact, but that swelling within the bone is going to create pressure within the periosteum, and the periosteum is highly innervated, so fractures are painful, so it's going to create severe pain. Plus, there's the release of all those inflammatory mediators like histamine and bradykinin, which will also contribute to the pain. And there are some systemic signs of inflammation that will occur. So when we look at the healing of the bones, remember we said the hematoma forms, and there is this fibrin network that will be formed, and that fibrous network is going to create this granulation stage. In this granulation stage, there's going to be a lot of white blood cells and macrophages in the area. It's going to try and remove some of the debris, right? Out with the old and in with the new type of thing. There are fibroblasts that are there that are going to lay down new collagen, because 1/3 of bone is collagen. So we need protein, we need vitamin C, right? Very important in order for our bodies to produce collagen. Then there's chondroblasts that begin to form new cartilage. So the hematoma forms, then you go into the granulation stage, it's going to remove some debris, and now the fibroblasts lay down some collagen, and chondroblasts are going to lay down cartilage, and now we start to form this collar, this procallus collar. And the purpose of this collar, it's really this fibrocartilaginous connection. It forms a bridge between the two fragments. And this procallus is designed to act as a splint. So this procallus, the forming of it is extremely important. This procallus collar, which forms the bridge, the connection between the two bones, is going to try and act as a splint to hold it in place. And then eventually, the procallus will be replaced by a bony callus. And this is done by the osteoblasts, which are going to lay down new bone from the periosteum, which is the outside of the bone, to the endosteum, to the inside of the bone, to generate new bone. After that callus forms, it's going to go through a remodeling stage, which is really the final stage. And the remodeling is this balanced relationship between the building up of bone and the breaking down of bone. Osteoblasts build up, osteoclasts break down. Osteoblasts build, the osteoclasts break down. And we want them to be in balance, because if the osteoclasts are working at a faster rate than osteoblasts, that's what osteoporosis is, or osteopenia. Okay? And this can take about 3 to 4 months for it to fully heal up. So you can look at this picture and you can see, okay, here we have the fracture. We can see that there's bleeding, so we see the hematoma. And then we start to see this fibrin mesh. We see this granulation tissue starting to form. We start to see the chondroblasts and some osteoblasts forming. And now we get this fibrocartilaginous collar, right? This collar is starting to create this bridge between the two fragmented sides, right? So here's the bridge, and now we could see the swelling, right? You could see the edema, so it's starting to push out on the periosteum on both sides, but you could still see the bony callus, right? It went from the fibrocartilaginous procollar, the procallus phase into now the bony callus. And now we could see it starting to degrade it. The osteoclasts come in, they're going to break it down, and then osteoblasts will build up. The edema is starting to come down, and eventually, after the remodeling in a few months, you have fully healed bone. What are some of the factors that can affect bone healing? Well, the amount of local damage, obviously, the proximity of the bony ends that fractured. Are they too far apart? Do they need surgery where we need screws and rods? Or can the gap be minimized just through manipulation? Is there the presence of foreign material or infection? That can certainly complicate things. Or are there systemic problems? Are there pre-existing conditions like diabetes, anemia? Is the person on glucocorticoids, which will impact blood vessels? Does the fracture site have good or bad blood supply? What's their nutrition look like? Are there deficits, especially for vitamin A, D, K, and C? These are all needed for healthy bones. Some of the complications of fractures, wherever there's trauma, muscles will go into spasm, and that can also happen from nerve irritation as well. Infections, right? If there's a compound or an open fracture, you can get an infection, or from surgical intervention, right? This takes place in a doctor's office or in a hospital setting, so there's loaded with bacteria and viruses in there, so you can get infections. Also, ischemia can result from compression, especially if there's improper fitting of a type of cast and it shuts down the blood supply. Another complication is something called compartment syndrome, and this occurs with extensive inflammation, such as a crush injury. What will happen is the fluid is going to increase the pressure within the fascia. Remember, fascia is going to surround muscle, blood vessels, organs. All tissues are pretty much surrounded by this fascial sheath. And the fascia, it doesn't expand. So when you have this buildup of inflammation and fluid, and it gets trapped under that fascia, you get this compression of other blood vessels and nerves, and it really creates severe pain. And then ischemia, right? Lack of oxygen and blood supply. And then there could be necrosis of the muscle. This becomes very painful, so they have to actually drain it. They do need to do a fasciectomy where they go in there and they have to make a hole to release the pressure. It becomes a medical emergency. Some other complications of fractures could be a fat emboli. Remember, in fat, in that medullary cavity, there is yellow marrow. It's triglycerides, it's fat. It can convert on demand into red marrow if the body needs it. There could be nerve damage. There are many people who are in a car accident and they step on the brake, they hit the car in front of them, and then the whole hood compresses back. And when their foot is slamming forward and the hood of the car pushes back, they could break the fibula. And right along the head of the fibula is the common peroneal nerve. And when the common peroneal nerve gets fractured, you can't dorsiflex the foot. So, nerve damage is another complication of fractures. The failure to heal, just simply non-union, or development of a deformity during healing. And then if it doesn't heal properly, now you have two bones that are articulating with each other at a joint that aren't in the best alignment, and then you start to get degenerative joint disease or osteoarthritis. Right? When you have two bones that are not aligned and they continue to move and function, they strip away the cartilage and they degenerate and break down. Signs and symptoms, pain, right? Severe pain can also cause shock. We spoke about that. Swelling and tenderness at the fracture site. Open wound, right? Compound fractures. Possible deformity. Crepitus, that's another sign, is when people move certain ways, they'll hear little cracks and clicks, almost sounds like sand between the joints. That's called crepitus. It's this grating type of sound. Another sign is also nausea or vomiting, and we see that specifically with spinal fractures. Okay, so how are these treated? Well, the whole idea is let's reduce the fracture, which when you hear that word reduce, it means can we restore the normal positioning of the two bones together? And it can be done naturally or it can be done surgically. So a closed reduction is just using the pressure of manual manipulation and traction to restore the balance. Sometimes the patient is conscious for this, and they, tell them that it's going to be a little painful, and 1, 2, 3, boom, and then it's done. Um, Open reduction is when they need surgery to align, or they have to insert pins or screw in rods or plates for the best alignment. That's an open reduction. Okay, let's talk a little bit about dislocations, strains, and sprains, muscle tears, repetitive strain injury. Okay, this is more on the musculo side instead of the skeletal side. Well, still with dislocation, this is when the bones aren't necessarily breaking here, but there's a separation of the two bones at the joint. And that will result in a loss of contact and good connection between the two articulating surfaces. And this can be from trauma, for sure, or just other pathologies such as rheumatoid arthritis, which is, not to be mistaken for osteoarthritis, which is the same as degenerative joint disease. Rheumatoid arthritis is more systemic. It can affect multiple joints, whereas degenerative joint disease, aka osteoarthritis, focuses in on just one particular joint. When there is a dislocation, ligaments are going to be affected. And when ligaments are stretched beyond their normal anatomical limit, we call it a sprain, right? Ligaments hold two bones in alignment. Nerves, right, can be damaged, and so can the blood vessels with dislocation. So here's an example of one. Here's the clavicle. Here's the coracoid process, acromion process, the glenoid fossa or cavity. Here's the head of the humerus, which should be articulating with the glenoid cavity. It is a very common joint, the glenohumeral joint, to dislocate, because if you look at the size of the head of the humerus in relationship to the glenoid cavity, when I teach anatomy and physiology lab, I typically describe this as a golf ball sitting on a golf tee. This is much larger than this. This is very shallow. It's not very deep like the acetabulum of the hip, so this can easily dislocate. The osseous depth of this is not designed perfectly for this, so there's some soft tissue structures in here called the glenoid labrum, which is a cartilaginous ring that's designed to make this a little bit deeper. And still, with that, it's not good enough. So the body creates the rotator cuff muscles to try and add to the joint capsule and make it a little bit more stable. This is what it looks like on an X-ray. There's way too much of a gap between the head of the humerus and the glenoid cavity, so this is a dislocation. Here's another dislocation. This is the elbow. This is the trochlear groove. This is the olecranon process. This is the distal end of the humerus, where the trochlea is supposed to sit in the trochlear notch, and it dislocated. This is the head of the radius and the radial shaft right here. Look, dislocations, the signs of the symptoms: pain, swelling, bleeding, deformity, and loss of movement. The whole idea is to this, it's kind of like with a fracture. Let's try and reduce it. Let's try and realign it. And after that's done, let's do some therapy. And, strengthening the soft tissue around it is trying to create this plan so that the repeated dislocation doesn't happen over and over and over again. That's where soft tissue and reconditioning comes into play. Strains and sprains, these terms look a lot alike, but they're not the same thing. A sprain is when a ligament is is stretched beyond its normal anatomical limit. A strain is when a tendon is stretched beyond its normal anatomical limit. So just remember that tendon has a T, and so does strain with a T. And tendons are just an extension of muscles, muscles attached to bones by way of tendons. Sprains are bone to bone, right? Ligaments go bone to bone. An avulsion is when a ligament or a tendon is completely separated from its bony attachment. That's when it avulses. Okay. Sprains and strains, what are the signs and symptoms? Pain, swelling, discoloration, loss of strength, and again, reduced range of motion. Think of an ankle sprain. If the ankle plantar flexes and inverts, right, like slipping off a curb, and the lateral side of your ankle swells up, it's going to be painful, it's swollen, it definitely turns black and blue, you don't have strength, and the range of motion becomes limited. And the whole idea is trying to immobilize it and keep it still to try and prevent some tissue damage and promote healing. Think of an injured dog. If a dog injures its paw, it's going to lick its injured paw, it's going to sit in the shade and drink water, right? Okay, muscle tears. Muscles can tear, and when they do, they can tear right in the middle, right, the belly of the muscle, or right at the point of the attachment to the bone. Those are just the two common places that they're going to happen. Typically from direct trauma or from overexertion, meaning there's too much tension being generated and your body can't handle it. So it tears. There's a first degree, second degree, and third degree tear. A first degree tear is when only a small portion of the muscle fibers are torn. You're going to have some, mild pain. There's going to be a little bit of a loss of strength and range of motion, right? That's going to be like a bad strain, a muscle strain. The second degree involves much of the muscle, but again, it's not a complete tear. Now the pain is more severe, and there's a substantial loss of strength. Not minimal, substantial. And a substantial loss of range of motion. Now we could say it's a second degree tear. Excuse me. A third degree, give me a second just to get some water. A third degree tear, now this is a complete tear across the width of the muscle. It's unable to contract, right? If the muscle is torn, you don't have a full contraction, and you're not going to be able to really to move the joint at all. So first, second, and third degree muscle tears. Repetitive strain injuries are as it sounds. The disorder can affect muscles, tendons, and nerves. It's going to develop over time, and it's typically associated with work or sports or exercise that people do the same thing over and over and over again. People get repetitive strain from sports, doing the same type of exercise over and over again, doing the same type of work, the repetitious movement of either heavy lifting or always twisting in one direction or always putting things on shelves so their shoulders end up getting bursitis or subluxations of the lumbar spine, and then twisting, then they start to blow out discs and they get disc bulges or herniations, tennis elbow, golfer's elbow, even carpal tunnel syndrome. These are typical examples of repetitive strain type of injuries. Carpal tunnel syndrome, right? This one's pretty common. It happens at the wrists from repetitious overuse of the wrist and finger flexors. And then what happens is all of the finger flexors, like the flexor digitorum profundus and the flexor digitorum superficialis, they all thicken up. And the tunnel, the carpal tunnel, is created by the volar ligament or the transverse carpal ligament, aka flexor retinaculum, that is superficial on the anterior side, And then on the dorsal side, you have the carpal bones. And the flexor retinaculum goes from the lateral to carpal bones to the medial to carpal bones, kind of like a bracelet. And that's the roof. And then the floor of the tunnel is the carpal bones. And there's the tunnel. And then what runs through it are all those flexor tendons plus the median nerve. So with repetitious wrist flexion and finger flexion for years and years and years, if someone's a mechanic or they're a barber and they're cutting hair or they're a massage therapist or whatever it is that they use their fingers over and over and over, the muscles thicken. And when the muscle or tendons thicken that run through the carpal tunnel, the space in the tunnel gets smaller. And if the space in the tunnel gets smaller, then whatever's in it is going to get compressed, and that's the median nerve. And when that happens, you get numbness and tingling or radiating pain to the first, second, third, and half of the ring finger. That's carpal tunnel syndrome. And typically, it's nocturnal pain. It can get worse at night. Repetitive strain injuries, diagnosis is really the history. Sometimes x-rays or MRIs also. And the treatment is rested, ice or heat. Ice is if something is painful, you ice it. And if something is tight, like a tight muscle, then you would put warmth on it. Just think of a bee sting. If a bee sting is hot, red, and swollen, you're not going to put heat on it. You're going to put ice. And if something is already inflamed, heat, you're not going to add more heat to it. You're going to put ice on it. If something is tight, like a tight pickle jar, you put it under hot water and it expands. So when muscles are tight, you can put heat on it. When something's painful, you put ice on it. Anti-inflammatory drugs, PT, physical therapy, surgery, education, of course. These are all preventative measures from an educational perspective. Okay, let's look at some of the bone disorders like rickets and osteomalacia, which are kind of similar, just depends on the age of the person here. We'll talk about Paget's, osteomyelitis, and some bone tumors. So rickets and osteomalacia, this is going to result from a deficiency of vitamin D and phosphates. It's caused by an inadequate amount of calcium and phosphate, and these both are needed to help with the calcification and mineralization and hardening of bone. There could be dietary deficits of consuming these things. There could be the malabsorption, some sort of intestinal issue where the person's not absorbing it, or from the prolonged intake of phenobarbital. This is a drug that's used to try and manage seizures. The vitamin D deficiencies come quite common in people in the northeast especially due to lack of sun exposure. We said from about mid-September to mid-May, the sun is not hitting our skin at a 90-degree angle, and that's where supplementation is very important. Blood tests should be done twice a year, as I said in a previous lecture, in the summer months and then again in the winter months, so that you know how to modify the vitamin D supplementation. I would say, generally speaking, I'm going to have to say 8 out of 10, 9 out of 10 of my patients are on vitamin D supplementation. We do it based on blood tests. It's really important to look at the 25 hydroxide, the 25-OH blood test, and we want to see that number somewhere around 50. Typically, most labs like to see it above 30, but from a functional standpoint and an optimal standpoint, 50 to 55 seems to be the right number. It just, to me, it never makes sense if it's 30. Remember, lab numbers are given based on the community. And most people, when they go to doctors and they're getting blood work done, they're in an unhealthy state to begin with. So the numbers that we get from labs are based on sick population of people, not the people that are really optimally well. So in the functional medicine model, there's a consensus that we would like to see that number between 50 and 55. So I would say that 8 to 9 out of 10 of my patients are on vitamin D3 with vitamin K in it, and we're starting them at typically 5,000 international units. Sounds like a lot if you look at what is recommended, but it is not. It, it it takes a lot of vitamin D to try and raise the vitamin D levels on blood. There are some patients that I have on 10,000 international units. Some are on 20,000. So 5,000 is pretty much our starter kit. I have, 3 young kids, and we give them liquid vitamin D. It's a dropper, and each drop is 1,000 international units. So it's about, I've heard some people say for every 25 pounds a person weighs, 1,000 international units to start. So 5,000 isn't a lot. Okay, what else did I want to say about vitamin D? It's a hormone. Our bodies make it. But it is a conditionally essential vitamin. It's not essential, but it's conditionally essential. There's a difference. Conditionally essential is, are you living in certain conditions in which it's essential to take it in a vitamin form? It's not considered it's not considered essential because we can actually manufacture it. But during September to May, here in the Northeast, we can't. So we say it's conditionally essential under those conditions. If you live in a different climate, like maybe Florida or California, maybe it's not needed because you are outside quite frequently. You could be outside for 15 minutes, 20 minutes, just getting sun exposure to your arms, your face, your legs, and probably make 15 to 20,000 international units of it. And you can never overdose on vitamin D from the sun. Okay, it just doesn't happen. Okay, rickets is seen in children. Okay, osteomalacia, we see it in adults. Rickets is going to lead to weak bones, and it will create this bow-legged deformity because think of the legs as struts. And it's keeping the body upright. But when they're weak and you have weight pushing down, it's going to bend and bow these out. So these are called bowed legs. Now, osteomalacia is very, very similar. This is seen in adults, and it also leads to soft bones. It can result in compression fractures. Patients present with painful proximal muscle weakness, especially around the pelvic region. But they will have decreased bone density. They're going to have decreased vitamin D levels and calcium levels and phosphate levels as well. Okay, Paget's disease is known as osteitis deformans. It is a progressive bone disease with high bone turnover, and when it builds up again, it's just disorganized. It's disorganized bone matrix formation. So when these osteoblasts lay down their extracellular matrix, it's not organized. So it begins with this increased osteoclast activity, right? Osteoclasts break down, causing lytic, right? Lysis, it's going to break down bone. And then it's going to be followed by an increased osteoblast activity. But when it produces the bone, it's going to be disorganized, which creates a weakness of the structure because it's not structured in an organized way. If the structure is poor, the function is going to be poor. So then you start to develop these pathological fractures. Okay, it's common in adults that are older than 40 years old. The exact cause has not been established, but we do know that there is some association with vitamin D levels and calcium levels and phosphate levels. So it would be important to keep track of those. With Paget's, they're often asymptomatic, and the bone pain just may be the very, very first symptom. And in the vertebra, they can get a compression fracture. And when you get a compression fracture, it will result in a deformity of a kyphosis, which is this hunching over, this rounded back type of deformity. And that would make sense because remember that picture we showed earlier of the x-ray of a compression fracture where the anterior part of the vertebra wedges. In the skull, you'll see like a larger head. That's because the osteoblastic activity, it just thickens the skull. So a person may have trouble putting on a hat. It just doesn't fit anymore. The increased pressure can result in headaches and compression of the cranial nerves. That's a pretty bad complication of it. And plus, the bowed tibias also. Osteomyelitis, this is a bone infection that's caused by bacteria or fungi. An infection that could spread to the bone is really the cause, and this can happen, following a surgery. It could be secondary to the insertion of a structural insert, right? Like putting in pin, or after a joint replacement, you get some bacteria in there, and you can get osteomyelitis, a bone infection. I think I mentioned this earlier with one of my patients who had the kidney infection. He had a bacterial infection of the kidneys and ended up spreading into his ileum. Local inflammation, bone pain, fever, and excessive sweating. This was the key sign that my patient had. He was on my table. He had come in after leaving a hospital, in fact. He left the hospital, was still in pain, and he came to my office to help him. And when he was on my table and I lifted up his shirt to look at his lower back where he was painful, he had little sweat beads there. And I saw him on my table and he looked like he was shivering. So I had him go to the bathroom, fill up a cup with some urine, and when I checked his urine and I ran it through the computer, his white blood cell count was through the roof. And he did have a fever. So I sent him to a good friend of mine to evaluate him as a second opinion and said, absolutely, he's got a bad kidney infection and we got to send him for an x-ray and MRI. Now, keep in mind, he had just left the hospital. So he sent directly back to the hospital, MRI, and they saw the infection. And he had to go on IV antibiotics for a while. Okay, so he had the chills. He had a fever, chills, excessive sweating. The treatment was aggressive IV antibiotics for him. Okay, he didn't need surgery, but he did need the antibiotics. Let's see. So in terms of bone tumors, there could be primary or secondary tumor. The primary tumor, most are termed sarcoma. Remember, the term sarcoma means it involves connective tissue, and they are malignant. A secondary tumor, this is when it metastasizes from other tissues. Okay, a common site of a secondary tumor can be from the breast or the lung or from prostate tumors. Osteosarcoma, it's the most common primary neoplasm of bone, and it typically occurs at the metaphysis. Remember the parts of the long bone? You have the proximal and distal epiphysis, and then there's the metaphysis, and then there's the diaphysis. So between the diaphysis and epiphysis is the metaphysis, the long bones of the femur, the tibia, the fibula. Ewing sarcoma is another malignancy, but that's commonly found in the diaphysis. Okay, so if it's more proximal at the metaphysis, it's an osteosarcoma, and if it's a little bit more distal in the diaphysis, they call it a Ewing sarcoma. It's common in children, adolescents, and young adults. Both can metastasize, commonly to the lung. The clinical manifestation, it's steady bone pain, not at movement, but at rest, and the pain is worse at night. Okay, it can get worse with activity, but the clear warning sign for cancer is deep set bone pain when they're not doing anything. The treatment is going to be surgical excision, right? Removal of it, sometimes amputation and chemotherapy. So here we can see, here is one of the This is in the epiphysis. This is the metaphysis. So this is your osteosarcoma. Here it is here, and here it is here, osteosarcoma. If it was up here, more in the diaphysis, that's your Ewing sarcoma. Osteochondromas, these are malignant tumors. Here's the word chondroma from cartilage. Common over the age of 30. It's commonly found at the muscle attachment points, seen in the pelvis, the shoulder girdle, and these osteochondromas can metastasize to the lungs. And again, the clinical manifestation is going to be pain, and these develop late when the tumor is more advanced, and the treatment here is surgery. So whereas osteochondromas found, these are malignant tumors that arise from cartilage. All right, let's look at muscular disorders, muscular dystrophy and fibromyalgia syndrome. There is another condition in terms of bones, that's osteoporosis, but that'll be discussed in one of your case studies, okay? Let's look at muscular dystrophy. It's a group of inherited disorders. There are many different types. It varies in the type of inheritance, the body, the area, the part of the body that's affected, also the age of the onset, and how fast it progresses. But the result is degeneration of the skeletal muscle over time. And you can see here's Duchenne's muscular dystrophy. It affects males. The age of onset is about the age of 2 to 3. And this affects the hips, the legs, and the shoulder girdle. And it's in that order. Okay, it ascends. These children have difficulty walking they just have difficulty walking upstairs because of the weakness to the hips and the legs and the shoulders, right? You can't even hold on to the banister. This progresses pretty rapidly. Duchenne's muscular dystrophy. It is the most common type is Duchenne's. It affects young boys, and it's a deficit of a membrane protein, right? When we talk about muscle proteins, there's actin and there's myosin. Those are the structural, the contractile proteins, and then we have these regulatory proteins like troponin and tropomyosin, but then we have structural proteins, and one of them is called dystrophin. So you have muscular dystrophy. It causes a degeneration of the muscle, but also a necrosis of the muscle. Skeletal muscles are then replaced by scar tissue and by fat. So it gives the appearance that when you have muscle it becomes thicker with fat and scar tissue, it is a hypertrophic appearance, but it's a false hypertrophic appearance. It's thicker and larger, not because they're muscular and strong. It's just being replaced by scar tissue and fat. The signs and symptoms of Duchenne's, it's motor weakness. It can happen between the ages of 1 to 5. I think on that last page it said 2 to 3. But it's weakness in the pelvic girdle. They have this waddling gait, almost like in the movie E.T., how E.T. waddled. Difficulty in climbing stairs, that's classical. And then later it starts to progress to the shoulder girdle because it ascends. It starts to move up superiorly, from inferior to superior. A common finding is called Gower's maneuver, where they have to push up to try and stand in an erect position. Their tendon reflexes are reduced, whether you tap over the biceps tendon or patellar tendon. They start to develop kyphosis and scoliosis. There's respiratory insufficiencies and infections. There's cardiac abnormalities and sadly death within 15 years of onset. The diagnostic test for this, it's the identification of the genetic abnormalities. They also look at increased creatine kinase levels. When this rises, there's muscle damage, either in skeletal muscle or cardiac muscle. EMG, which is electromyography, muscle biopsy, and then blood tests that show abnormal dystrophin levels. The treatment, there really is no curative treatment available for muscular dystrophy. It's just moderate exercise to try and maintain the muscle mass that's there, supportive appliances to try and make life a little bit easier, physiotherapy, chiropractic care, occupational therapy. All of these things are designed to maximize function and to help them adapt. Massage therapy reduces pain. It decreases stiffness. Sometimes ventilators are needed in case of respiratory failure. And there's lots of ongoing research that's being done for genetic therapies. Fibromyalgia. This is a group of disorders that's characterized by pain and stiffness. It affects so many different muscles and tendons and soft tissue. It's not a joint problem. It's fibrous, fibro, and myo. Myo is muscle, and algia, whenever you see algia, it means pain. If it's neuralgia, it's nerve pain. Myalgia is muscle pain. Arthralgia would be joint pain. It can be aggravated by sleep deprivation, stress, and fatigue. But to diagnose it, there are specifically 18 tender points which could be stimulated, and they all have to be painful to get that diagnosis. Specifically 18 tender spots that are located throughout the body, neck, shoulder, trunk, and limbs. I have a picture that shows these 18 spots. It's generalized aching, fatigue. It affects the sleep. It leads to depression, and there are irritable bowel syndrome symptoms, meaning that they go from constipation to diarrhea. Here are the 18 spots. You can see at the neck, around the traps, at the elbows, the knees, front and back, even around the hips. So there's classically 18 tender spots that have to be tender to be fibromyalgia. The treatment is really trying to avoid and reduce the stress. Regular exercise in the morning when they have most of their energy, fueling the mitochondria as best as possible, right? The energy centers of the body. Mitochondria need glucose, and they need B vitamins, and they need the right fish oils and magnesium and iron. So it's knowing how to resuscitate mitochondria as well that can be helpful. Coenzyme Q10, all very beneficial. Rest is needed to rebuild the ATP. Application of heat and massage, sometimes analgesic drugs, antidepressants as needed, and the non-steroidal anti-inflammatory drugs. Let's look at the difference between osteoarthritis, which is OA, aka degenerative joint disease, and RA, which is rheumatoid arthritis. So osteoarthritis, or degenerative joint disease, is the most common form of joint disease. It is chiefly a disease of aging. This happens over time and the right type of conditions. 90% of all people have radiographic features of osteoarthritis in the weight-bearing joints by the age of 40. Now, these are 90% of people. It doesn't really say whether these are people who are under, let's say, regular alignment and regular chiropractic care, or 90% of people in the general population. Because I have x-rays on patients that are well over 40 that have no sign of degeneration in weight-bearing joints. And I have people that I take care of in their 70s and 80s where I have x-rays on them from 70 to 80, and there's no advanced changing of arthritis in their weight-bearing joints. So it's a combination of things. I remember years ago I was testifying on behalf of a patient in court, and my patient had degenerative joint disease at C5 and C6. And the opposing attorney, I remember they said to me, Dr. Lindner, isn't it true that everyone has some degree of arthritis and it just comes with age? And I remember saying it's not entirely true. And they said, well, how can that be? And I'll remind you, my patient at that time was probably between 50 and 55. And I said, it's not entirely true because this patient only has degeneration at C5 and C6. If you're saying this is a result of age, how old is C3 and C4? How old is T4 and T5 of their spine? Why, if it's age, all the bones are the same age? Why is it only at C5 and C6? I'll tell you why. Because my patient had a flexion, an acceleration deceleration injury from a whiplash, and flexion and extension takes place at 5 and 6. And those displaced a little bit, and over time, due to poor alignment, they degenerated. Okay, so there's a lot of factors involved. But I would say that 90% of people in a general population that are not receiving chiropractic wellness or chiropractic alignment or adjustments to keep their spine in ideal alignment, as well as their hips and their knees and their feet, yes, that would be true. Degeneration is wear and tear it's a wear and tear joint disease is what DJD or osteoarthritis is. The articular cartilage, which is hyaline cartilage, becomes damaged. The surface becomes very rough, it becomes worn. And when that hyaline cartilage becomes damaged, it releases these enzymes. These enzymes further accelerate the disintegration of the cartilage there. And remember, cartilage is not vascular, so it's not going to get nourishment quickly. Cartilage only gets its circulation from synovial fluid. Then you start to get the osteophytes, which are little bone spurs that develop that try to create more stability, but they have negative consequences. You can get cysts that are there. And then sometimes these osteophytes and cartilage can actually break off. The joint space between the two bones become very, very narrow. You can get secondary inflammation of all the surrounding tissues. You get normal loss of the normal range of motion because the structure becomes distorted, so does the function. And you get pain on weight-bearing joints, the vertebrae, the discs, the hips, the knees. You don't get lots of degenerative joint disease in the elbows or shoulders unless it's secondary to some trauma that creates misalignment of those joints that just doesn't get rectified. So here is degenerative joint disease. We can see that there are some cartilage fragments here. We see that there's erosion of the cartilage here. You can see the space on this side is pretty narrow. Here we have a cyst. This is a bone spur that's here. This is degenerative joint disease, targeting one joint. The etiology, the primary form, is weight-bearing, obesity, and having these things over a period of time. The secondary form is going to follow some sort of trauma or repetitive use. And the diagnosis is really through x-rays. You can visually see a decreased joint space. You can visually see osteophytes. There's thickening of the dense subchondral bone, and many times you can see these bony cysts that develop. So this is the knee joint. Here's the femur, the tibia, and the fibula. This is a nice, equally distributed joint space, nice and even. But here on the medial side, we can see it's degenerated. This can happen a lot from having excessively pronated feet. I see loss of joint space along the medial meniscus. Commonly in about 7 out of 10 patients are going to have flat feet or pronation. And over time, it results in degradation of the medial meniscus, primarily from the enzymes breaking down little by little by little. Okay, here We can see these are vertebrae of the lumbar spine. This is bone spurs. Just want to show you what they look like. Here, it's starting a little bit, but we want this anterior part to be more vertical. Here we see a sharpness. Here we call it like lipping and spurring, where this is coming up, this is going down, like two lips are trying to kiss. We call that lipping and spurring, but they're bone spurs. And eventually what's happening is, because there's degeneration that's happening and it becomes unstable, the base of support of the vertebrae are trying to become wider. The wider it becomes, the more stable it becomes. And if it doesn't get rectified or fixed, then eventually this grows up, this grows down, and then they fuse. And now you have limited mobility, as seen here. This looks like there's a fusion here. Okay. Here's a good, healthy hip joint here. This is degeneration. This eventually is going to need a hip replacement, or at least a hip resurfacing, but this will probably, the acetabulum has to be made deeper, and this probably has to be smoothed out, or they'll put a cap on it, one way or the other. A hip replacement or a hip resurfacing, one of the two. Osteoarthritis, the clinical manifestation. Initially, they're going to get our stiffness. They're going to get up in the morning, things are going to be stiff, and then eventually as they start moving, it gets a little bit better. Throughout the day, it can get worse, especially with weight-bearing activity. And then things can develop, especially in the hands. They can get Heberden nodes or Burchard's nodes. They're just swollen knuckles, that type of thing. It's just specific for which knuckle. So when we're looking at the distal phalange, right, the joint closest to the fingernail is the distal interphalange joint. When that becomes swollen, they call it Heberden nodes. When the other knuckle that's proximal to that gets swollen and enlarged, they're called Bouchard's nodes. That's the proximal interphalange joint. When you bend the fingers, and if they have arthritis in any joint, if you hear the grinding, sandy sound, that's called crepitus. Common to hear that in the knees when people bend their knees and they try and stand up. The treatment for it, osteoarthritis, is the stress that's on the weight-bearing joints need to be minimized. And if they need to, they could use some assistive devices like canes. Still, exercise is important, but perhaps not the weight-bearing exercise. So swimming and aquatherapy may be more beneficial, because you still need to move the joints and circulate the synovial fluid around. By circulating the synovial fluid, that's what helps to nourish the cartilage cells and allows them to regenerate. If the synovial fluid from movement isn't circulating, then the cartilage cells can't regenerate, but they degenerate, and then you get further osteoarthritis or degeneration. Also, what is very beneficial, I end up doing a weight-bearing thermographic scan on my patients to look at their feet, and then we make these custom orthotics for them, for these inserts. Not because they have foot arthritis, but because they either have knee degeneration, hip degeneration, or they have lumbar spine disc degeneration. And I've even made foot orthotics for patients that have degeneration in their neck, primarily because it acts as a shock absorber to decrease the amount of loading force on their spine. Because each time the person takes a step, there is this loading force that's transmitted to all the joints. By the time the force is transmitted to the neck, it is much less, but still necessary. Other treatments for osteoarthritis: massage therapy, physiotherapy for rehab, chiropractic for the spine, acupuncture, occupational therapy, glucosamine chondroitin sulfate supplements. Very, very helpful. Especially lots of research on that for the spine as well as the knee joints. It takes at least 1 to 2 months to get the benefits of it, so patients shouldn't lose hope. You have to remember that the joints are avascular, so they may have to go through a full bottle of supplements before they actually get the benefit. But great nutraceutical companies know how to make the right formulations that allow the higher absorption rate of these things. I don't. I would never advise my patients to go to, like, a GNC or any of these local food stores for supplements. Vitamins and supplements should be recommended and prescribed only by a healthcare provider. This is not something that people should go on, Google and explore and then go and get themselves. A good reputable doctor should be able to guide you and help you. Injections of synthetic synovial fluid like hyaluronic acid. NSAIDs are helpful, analgesics. Sometimes a surgical joint replacement is needed. Now let's talk about RA, rheumatoid arthritis. Different than degenerative joint disease, they're not the same thing. So when someone says, oh, my mom or dad or grandma or grandpa have arthritis, well, what type of arthritis? Is it degenerative joint disease or is it osteoarthritis? So you have to be very specific. So blood tests can often tell if it's a rheumatoid arthritis compared to a degenerative joint disease because there are some factors that we could look for on blood. Also, rheumatoid arthritis is a systemic inflammatory disorder. It is considered an autoimmune disorder. Higher incidence in women than there are in men. This is true for most autoimmune conditions. The peak onset for women is between 40 and 50 years of age. For males, it's between 60 and 80. The idiopathic etiology, susceptibility to RA is genetically determined with multiple genes that contribute to RA. The pathophysiology, if you look at synovitis, there is a synovial membrane that becomes very irritated. So it's an abnormal immune response with inflammation of the synovial membrane. It's going to become very red, swollen, and painful. And there are rheumatoid factor antibodies that are present on the blood. We call it RA factor. So one of the things that we check for on blood is something called RA factor. There is a pannus formation, which is the granulation from the synovial tissue that spreads over the articular cartilage. And then there's more destructive enzymes that are released that cause further joint damage. But the joint damage that is seen with rheumatoid arthritis just doesn't target one joint. It's multiple joints. It's usually both hips or both knees or both shoulders. It's not just one knee. When it's the hand, it's usually multiple joints of the hand or even both hands. So there is cartilage erosion, and it's typically creates an unstable joint. Okay? There is fibrosis that takes place because the pannus becomes pretty fibrotic, and when that happens, you're going to decrease mobility. There may even be ankylosis, which is really fusion or joint fixation that takes place if the deformity isn't treated. There is atrophy and spasms of muscles that take place. There's bony alignment shifts that can take place. And then there are specific contractures and deformities that develop, especially of the hand. Here we can see we have the synovial capsule here, and this is inflamed. We start to get this pannus that develops. We have a loss of cartilage, but notice it's symmetrical. In degenerative joint disease, it was like crushed on one side. Here it's symmetrically diminished throughout the entire thing. Here we're starting to see some ankylosis or fusion that's taking place as a result of the fibrous tissue. Here is where we get ulnar deviation of all the joints, right? You start to get this shift. Here's the ulna, here's the radius, here's the thumb. So you start to get this ulnar shifting or ulnar drifting of the digits. And then you get this boutonniere type of deformity of the thumb. Here's what it really looks like. Again, you could see the ulnar deviation. Again, rheumatoid arthritis doesn't just affect one joint, it usually affects both, and it looks pretty symmetrical. Here's the boutonniere deformity of the thumb. Rheumatoid arthritis has systemic effects. It's not just the joints, it can affect other things as well. It can result in fatigue, depression, anorexia, low-grade fever. It can affect organs, the heart as well. Iron deficiency anemia that is resistant to iron supplementation. That's usually another indication of RA. In terms of the joint signs and symptoms, they can vary. It's insidious, meaning it happens not overnight, it happens over a period of time. There's lots of achiness and stiffness, but it's symmetrical swelling of multiple joints with tenderness and pain. It's not just one joint, okay? The stiffness may recur after daytime inactivity or after strenuous activity. Rheumatoid arthritis can affect the proximal interphalange joints, the metacarpal phalange joints, the wrists, the knees, the ankles, the metatarsal phalange joints, but again, it's usually both wrists, both knees, both ankles. Synovial cysts can occur, and even rupturing of tendons can take place. Other signs of, keep in mind that it is systemic, so there could be ocular symptoms, there could be dryness of the eyes, the sclera of the eye can become inflamed, there could be interstitial lung disease, there could be cardiac symptoms, and even vascular symptoms. It targets a bunch of different organ systems, not just the bones. For the treatment here, it's the balance between rest and moderate activity. Also, the difference between heat and cold. It depends. When things are painful, you put ice. When things are feeling stiff, sometimes moist heat works. Physical therapy, occupational therapy, chiropractic, once again, these are all kind of fall within the manual medicine category. Physical therapy can help strengthen and stabilize joints, but physical therapy always works best with chiropractic care because you don't want to strengthen and stabilize a joint if it's not in alignment. You want to make sure that things are properly adjusted and in place, and only when that happens should you strengthen and stabilize. That's where they work beautifully together. Non-steroidal anti-inflammatory drugs, glucocorticoids if the inflammation is pretty severe, other analgesics for pain. There are disease-modifying anti-rheumatic drugs such as gold salts, methotrexate, hydroxychloroquine. You have to just be careful. A lot of these can really destroy the gut and the intestines and throw off the microbiome. You have to be pretty careful with this stuff. Let's look at infectious arthritis, gout, NAS, or ankylosing spondylitis. So infectious arthritis can develop in a single joint. The joint is red, swollen, painful, which will result in decreased range of motion. Here the synovial membrane is swollen like it was with rheumatoid arthritis, but there's purulent exudate. The causes here is there has to be a direct introduction of bacteria directly into the joint, such as a trauma or an injection with a non-sterile needle or some infection from a surgery. A secondary infection because of maybe bacteremia. Now, the treatments with antimicrobials over a sustained period of time is beneficial, and sometimes it requires IV administration of some antimicrobials. Now, gout or gouty arthritis, this used to be called King's disease because kings would drink drink wine and eat cheese, wine and cheese and meat. Um, it is a metabolic disease that's associated with the abnormal deposits of urate or uric acid crystals in the tissues. And it's common in males over the age of 40. It's hyperuricemia, which results from poor purine metabolism. It's going to be impaired renal excretion of the urate, and it's seen with a metabolic deficiency of an enzyme known as uricase. So these are urate crystals, and these can deposit in a single joint, most commonly the great toe. It just gets red hot and swollen, basically. The inflammation results in these uric acid deposits. It damages the articular cartilage. The joint becomes red, swollen, and really severe pain to the point where they can't even get on a sneaker, or they have to cut out the top of the sneaker of where the great toe is. That's how painful it is. There's the formation of a tophus, which is a large, hard nodule, which is the accumulation of those urate crystals. And the tophi causes the local inflammation and occurs after the first attack of gout. It's commonly seen on the extensor surface of the forearm. It can be seen on the great toe, and it can also be found on the auricle of the ear or the pinna of the ear. This is gout, hot, red, and swollen. Couldn't even rest like a sheet, like a bed sheet on it. That's how painful that would be. Here's the tophi of the auricle of the ear. The treatment is try and reduce serum uric acid levels, decrease alcohol, decrease organ meats, stay away from beverages that are sweetened with high fructose corn syrup. That's pretty much any soda. Any type of sweetened fruit juice has high fructose corn syrup. Increase the water intake. Absolutely. Again, remember the rule of thumb. Take your weight, cut it in half, drink that in ounces. And then there are certain drugs that can assist and help with the gouty arthritis. Let's look at AS, ankylosing spondylitis. It's a chronic progressive inflammatory condition. It affects the sacroiliac joints. We typically abbreviate that as the SI joint, the junction between the sacrum and the ilium, and then it moves up, right? It kind of ascends. It starts at the SI joint, then it moves to the intervertebral discs and the vertebra, and then it moves up to the junction between the vertebra and the ribs, so it can affect respiration and lung expansion. Common in men between the ages of 20 and 30. It's thought to be an autoimmune disorder, and there are some genetics that are associated with it. So the vertebral joints first become inflamed. You start to get this fibrosis and calcification. I think I have an x-ray here that I can show you, and then it becomes fused. The joint just fuses, and you get this loss of mobility and stiffness. The inflammation starts in the lower back because it really starts to ankylose and fuse at the sacroiliac joints, and then it moves up the spine. Then you get a kyphosis that develops. Osteoporosis can also happen. It's pretty common, and it's because of the lack of movement. When there's less stress that's placed on the joints, if you don't move it, you use it. If you don't use it, you lose it type of thing, the Wolff's Law. Lung expansion becomes limited due to the calcification of the costovertebral joints. That's the junction between the ribs and the thoracic vertebrae. Signs and symptoms: pain in the lower back, lots of stiffness in the morning, even pain when lying down, and the spine is just so rigid and stiff. There are some systemic signs. They're tired, there's fever, there can be weight loss, and uveitis, which are symptoms of the eye, especially the iris of the eye. There are some drugs that can be given to relieve the pain. Some daily exercise is helpful. The physiotherapy and chiropractic to mobilize the joints and try to limit the fusion, as well as occupational therapy. Here's you get this kyphosis. That's the kyphosis. I'll show you a better Um, I'll show you some x-rays that show this a little bit better. So here is grade 1, grade 2. I want you to look here. Here's the sacrum, and then here's the ilium. You could see here clearly the SI joints, right? You could see the space. You can see it here as well. There is some erosion that's taking place here, but where's the SI joint here? It's fused, right? Grade 4, complete fusion. There is no sacroiliac joint. If you look at the lumbar vertebra, okay, looks pretty okay here. We start to see a little bit of some shiny corner syndrome here. You start to get these bright spots in the corner. Then you start to get, here's a little bit of a syndesma fight, or like a spur, a little bit one right here, right? But then you really can see the spurring here, the calcification here, the fibrosis, and then here and here. This is looking at the lumbar spine from the lateral view. So this is the sacrum, the base of the sacrum, L5, L4, L3, and L2. Now we're going to look at the spine from the anterior view. And here, again, you can see the sacrum. Here's the sacrum. Here's the ilium. You can see the SI joints look really nice and open here. Here it looks good. And then here's the lumbar spine. This is the 12th rib, L1, 2, 3, 4, and L5. You can see the disc space. They look pretty good. You can see there's clearly delineation between each vertebra. This is the spinous process, here's the transverse process, and here's the vertebral body. When you look here, we can see this type of bowing. They call this a bamboo spine, right? It's fusion on the sides. You can see this calcification, the spurring and calcification and fibrosis. So this is going to be very, very stiff. Now, if this person was moving frequently and exercising and getting these areas adjusted and getting good manual massage and chiropractic care and physical therapy, perhaps this would not be given an opportunity to actually fuse because they're constantly put in movement and motion. Here, you don't really see an SI joint, right? So the SI joint's fused and then it moved upward. That's AS, or ankylosing spondylitis.